A little rearrangement of the title, but I promise I will come back to exactly what Vanessa just said, and that is a LIFT trial. That's the Life Improvement Trial funded by Open Medicine Foundation. A special thank you to Linda Tannenbaum, who's in the audience. I will come back at the end, but I want to build a case for exactly why we are using two repurposed drugs in a large single center clinical trial, which I will describe. So uh, to build a case, I want to touch on some of our findings utilizing our major vehicle at Harvard and at the Brigham for investigating exercise intolerance in both ME and long COVID. And I'll cut to the chase here. Almost everything that we have found in ME appears to ring true as well in long COVID, so sometimes we'll slip and use them synonymously. So the major message that I want to leave the group here is that we have found with invasive exercise testing evidence of circulatory abnormalities, and maybe even more specifically, driven by a form of dysautonomia or neurovascular dysregulation. So I'm going to spend a little time telling you about how we found that and then again how we're attempting to treat it. So here's a table of contents for what I had hoped to show you. I'm going to introduce the group everyone may not be aware of the invasive form of a cardiopulmonary exercise test, so-called ICPET. Many folks know about the non-invasive version, which is quite useful. The invasive version includes two catheters that I'll show you in a minute, and they really allow a deeper dive into the pathophysiology underlying exercise-related symptoms. I'll echo what Braden said in the upright position largely. And what we have evidence, and Braden touched on this a second ago, of abnormally dilated blood vessels. On the venous side, we call this preload failure or insufficiency. And on the arterial side, we think there's some evidence of lax or dilated arteriolar resistors as well that lead to abnormalities of oxygen delivery to the exercising muscle mitochondria and its subsequent uptake. And then finally, I'll come back to the clinical trial design and tell you a little bit about our recruitment so far, called the LIFT study. All right, so the invasive CPET. We've been doing this for many years at Harvard. Don't need the audio. This gentleman agreed to be filmed. We do this about 7 times in the basement of the Brigham per week, and we have a satellite facility at Newton Wellesley Hospital outside of Boston that does twice that number or doubles our number. So the non-invasive version is shown here. There's a pneumotachograph which measures minute ventilation, the amount of air the individual is breathing during exercise, and then these small catheters are measuring pulmonary gas exchange, so O2 uptake or oxygen uptake and carbon dioxide output at the mouth. What's special about the invasive test are the two catheters. So in addition to the metabolic cart that measures these things, we have additionally a radial artery catheter and a pulmonary artery catheter that allow us to measure blood flow and pressures related to blood flow, both in the lungs, but more germane to ME and long COVID in the systemic circulation. And this, I'm just going to touch on a sort of a simplified version of our diagnostic algorithm using the invasive CPET. Up here is a non-invasive number that I will come back to repeatedly here. It's the VO2 peak. So at the end of an incremental cycling exercise test, we measure how much oxygen the patient is taking up. We can then in turn rule out a lung limit, and I'll use some general terms for this. We can determine whether there is a cardiac problem that's left heart or right heart. But where we end up almost all of the time in ME and long COVID are two other places. One is here. This is the preload insufficiency I mentioned. This, we believe, is failure of the big veins to squeeze down properly, to venoconstrict and physically move blood up northward against gravity, feeding the right heart, preload insufficiency. And it is ubiquitous in both ME and long COVID. And I'll show you our recent data on that, suggesting a majority of patients have this. Additionally, on the arterial side, we have found abnormalities in ME and long COVID, largely related to the inability to take up and use oxygen by the exercising muscle. And there's a differential diagnosis for that, and I'll touch on it. But it's reflected in our testing by inability to depress this mixed venous oxygen content. This is the amount of oxygen coming back to the tip of that pulmonary artery catheter that was in the gentleman's neck, and reflects the ability or inability in this case of the individual to take up and use oxygen. So let me tell you how we got into this about a decade ago with ME, and then subsequently over the past 5 years with long COVID. Preload failure was the first thing we stumbled upon using this testing with the help of Will Oldham, first author now at Brown. Um, we were increasingly referred patients whom we found out in retrospect largely met IOM criteria for ME/CFS for exertional dyspnea, that shortness of breath. But as it turned out, when we took a deeper dive and included fatigue and post-exertional malaise and orthostatic intolerance, the major and minor criteria at the time for ME/CFS. And we asked the question physiologically what ailed these patients compared to a normal cohort. The normal cohort were symptomatic normals. They came to us, we couldn't find anything wrong with them. And the answer in English was filling pressures of both sides of the heart. This is the right atrial pressure. This is the reflection of the left atrial pressure, the pulmonary capillary wedge pressure. And notice that the signal is strongest here, meaning depressed, abnormally depressed, at peak exercise, not so much at rest. So that's an important point. And these patients are all upright. So they are fighting gravity, which is the enemy in this case. And it's true on the left side of the heart as well. And then we attempted to regress these filling pressures against the time-honored VO2 max, or the maximum oxygen uptake. And the lower the filling pressures, the worse the VO2 peak was. And the major mechanism at the time we thought was related to cardiac output. So read failure to venoconstrict, move blood northward, cardiac output suffers, and then the VO2 max suffers. So this is what we call preload insufficiency, and we ended up here in this bucket. The next thing that we discovered several years ago with the help of Philip Joseph was the notion that there is a subset of patients, predominantly female, who additionally, in addition to the preload failure, have impaired oxygen uptake in the periphery. Excuse me. And this was the paper that initially described this. We also took a look at the prevalence of something called small fiber neuropathy, which you just heard Braden mention with respect to the gut. The classic diagnosis is with a skin biopsy. So with the help of Mass General and Ann-Louise Oaklander, we did skin biopsies in a substantial number of patients in addition to the invasive cardiopulmonary exercise test. And these are some of the findings. So the first novel finding we thought was this. There was a subset of patients with a lot of pulmonary blood flow, this is cardiac output, versus increased metabolism, this so-called high flow group. A lot of pulmonary blood flow, which is what we're measuring with the pulmonary artery catheter, but a lower VO2 peak, and the slope is increased, so here in the red. And the way that their oxygen at peak exercise, their VO2 peak is depressed, is inability to depress that mixed venous oxygen content. The muscle is not either getting or taking up the oxygen delivered out to the periphery, out the aorta, properly. So this was novel, and it mimics some findings that have been shown during tilt table tests in a subset of patients with POTS. Now, the hallmark of peripheral shunting, the hallmark of abnormal oxygen extraction in the periphery is related to potentially left to right shunting. And there is a cardiac version of that where oxygenated blood is pushed over to the venous side through a hole in the septum, usually of the atria. And we know our patients don't have that. So they all have a special measurement during a resting right heart cath that shows this doesn't exist. So what we think is this is going on in the periphery, and this is one tissue bed that I wanted to mention, the skin, where there are potential shunts between the artery and the vein that can open up dynamically. Braden mentioned CGRP. This is one of the vasodilator peptides that can open these shunts dynamically. And in the clinic, I ask patients, if you get in the hot shower, do you get lightheaded and your feet turn red? And there's a phenomenally high prevalence answer, yes. So some of this may be going on, but it may go on in other organ systems as well, the liver, the gut, the kidney, and even microscopically in the muscle. Abnormal dilation and shunting from artery, oxygenated blood over to the venous side, so it is not properly getting to the mitochondrion. Here's our most recent data with the help of Johanna Squires, who presented this at American Thoracic Society a couple of months ago in San Francisco. We had 335 patients at the time with ME, 72 patients with long COVID, and a smaller cadre of patients who were normal. And the theme should sound familiar here, but with much larger numbers. Long COVID is shown here, ME is shown here. This is the peak VO2. Generally speaking, across the board, on average, it's depressed modestly. This is 75% of predicted. But remember, there's a cohort that is pretty well preserved, and we can still find abnormalities with the invasive CPET. The abnormalities we find are preload insufficiency, so that's the right atrial pressure for both diseases versus normal, depressed, and that affects cardiac output across the board. For all patients, the cardiac output peak is depressed, but there is this subset of patients with both ME and long COVID with a lot of pulmonary blood flow and impaired oxygen extraction shown here. So very similar message to our prior work. This is the updated version, and it's the largest cohort of ME and long COVID with this type of testing that exists. So this was the other angle in the Philip Joseph paper that I began to talk about. In addition to the high flow group, we looked at the prevalence of small fiber neuropathy. Small fiber nerves, you heard from Braden, are associated with autonomic function in addition to pain sensation. They're diagnosed by skin biopsy, so this is an example of the epidermis with a paucity of axons, specially stained here, making the diagnosis anatomically. This small fiber neuropathy has been associated with fibromyalgia and with POTS previously, and we know it runs with autoimmunity and inflammation, which is beginning to build a case for how we're choosing two drugs for the LIFT clinical trial. Here's our most recent update of the prevalence of small fiber neuropathy using two biopsies, one down by the ankle, which is epidermal, the skin, the superficial layer of the skin, and then a second one up by the hip and the thigh, which is an attempt to get sweat glands and their small fiber innervation. And you can see that we have either definite or probable small fiber neuropathy in as much as 2/3 or even 3/4 of our patients with long COVID or ME/CFS. This is going to be presented in a couple of weeks in Amsterdam by Johanna and her colleagues. So this is where we end up with our current thinking that patients with both ME and long COVID have preload failure, failure to venoconstrict. They have additionally, at least a subset of them, impaired oxygen extraction, which may reflect peripheral left to right shunting, a high prevalence of small fiber neuropathy, and how do we know all of this is neurovascular? Well, one bit of data that we'd like to present is a randomized clinical trial using that invasive cardiopulmonary exercise test in a neuroactive drug, which is pyridostigmine or mestinon. Mestinon is FDA approved, so this is off-label use for a disease called myasthenia gravis. We know it increases acetylcholine, a neurotransmitter, and at the end plate in that disease and improves symptoms. May work in a different way in POTS and in ME and long COVID. So we did a clinical trial of roughly 50 patients. They were all women in the end with ME/CFS. They did their clinical invasive cardiopulmonary exercise test, then received either placebo, a single 60 milligram dose of pyridostigmine by mouth, or placebo, and then pedaled again with the existing catheters in the metabolic cart in place 45 minutes later. If they got drug, their VO2 peak went higher. If they didn't, it went lower. We were wondering if this is the beginning of PEM, very early, post-exertional malaise. The mechanism by which the VO2 peak increased if they got drug was cardiac output, got worse if they didn't get drug, with a second spin on the cycle. And the mechanism by which the cardiac output got better was improved right atrial pressure or venoconstriction. So we haven't changed the volume status of the patient. We've given a neuroactive drug, and they get better if they get it. The effect size is small here, admittedly, but proof of concept, I think that that's perhaps how Mestinon works in POTS and in these disorders, ME and long COVID. This is a diagram of where we think it works. This is the sympathetic ganglion, which is a cholinergic step. Pyridostigmine or Mestinon retards the breakdown of acetylcholine and enhances the adrenergic outflow to the blood vessels, and in particular, improve venoconstriction, cardiac output, and VO2 peak. So this is our interim conclusion and sets the stage for the LIFT trial to a large degree, that we have evidence of systemic vascular dysregulation in ME and long COVID. On the venous side, there's failure to venoconstrict. On the arterial side, we think that part of that oxygen extraction problem is peripheral left to right shunting, where one may begin to think about abnormal dilation of the arteriolar resistors. And there is an association with small fiber neuropathy given its high prevalence. And we think that neurovascular dysregulation is a proper term here, in part because we can correct it with a neurally active drug, pyridostigmine. So this sets the stage for the LIFT study, which is comparing two drugs. One is the aforementioned pyridostigmine, and the other is low-dose naltrexone. And just to say a little about low-dose naltrexone, I don't have time to tell you all about it. It's thought to be anti-inflammatory without immunosuppressing patients. Pyridostigmine, I've given you a major mechanism of action. It also, in the end, because it's parasympathetic, may be anti-inflammatory. Inflammation is particularly bad for nerves. Nerves cannot protect themselves. There is a so-called trail pathway, and the nerves cannot protect themselves. So we think ongoing, unbridled, post-infectious, autoimmune-related inflammation may be the root cause of the neuropathy, the autonomic neuropathy, abnormally dilated blood vessels, and exercise-related symptoms. So we are comparing pyridostigmine and low-dose naltrexone together, to pyridostigmine monotherapy with placebo, to LDN, low-dose naltrexone monotherapy, no pyridostigmine, and then placebo here. It's a large single center study, as I said, 160 patients, 1:1:1:1 randomization, double-blinded, placebo-controlled, 3-month study of ME and long COVID who meet Canadian consensus criteria for the disease. Our ultimate doses, if you're interested, pyridostigmine will be 60 milligrams 3 times a day, and the low-dose naltrexone in the end will be 4.5 milligrams taken in the morning. We don't know what the patient gets. They don't know what they get. We will not break the code until we hit our final number. The outcome variables are many. We've got all the omics covered, proteomics, metabolomics, transcriptomics not shown here. Peripheral blood mononuclear cells going to Maureen Hansen and Cornell. We've got well-validated questionnaires that are automatically downloaded. And we've got a wearable device, the Vivo Smart, I'll show you in a second. And then we've got a before and after non-invasive exercise test. This is called a SHAPE study. It's non-invasive. It's a metabolic cart. It gives us all the variables that we would get in a non-invasive cycling test. And it's self-paced. Individuals can go as quickly or as slowly as they need to. They can hold on if there's a little orthostatic intolerance. And so we will have both subjective and many objective measures of outcomes. So that's what I wanted to tell you today. I want to thank our team. This is our current team. We've got Johanna Squires here, Sarah shown over here, Sophia shown over here, Philip Joseph now at Yale, Wenzong, who's going to follow my talk, fabulous computational group along with Peng Li, Peter Novak, our neurologist collaborator at Brigham Faulkner. And then we've got the Open Medicine Foundation, Harvard team, special thanks to Ron Davis for this invitation and organizing this crew, many of whom are speaking here. And again, a special nod to Open Medicine Foundation, who's making all of this possible. So thank you.